Welcome to the deep dive, where we cut through the information overload and give you the essential insights from a stack of sources. Think of it as getting the key knowledge without you having to sift through all the academic journals yourself. Our mission is to make you well informed, quickly, with just enough detail to make it stick. Today, we are taking a deep dive into a shoulder injury that's surprisingly common, particularly among athletes who throw or do a lot of overhead work. But it also presents, well, a real puzzle for diagnosis and treatment. We're talking about superior labrum anterior and posterior tears, or SLAP lesions. This isn't just some abstract medical term, it's something that sidelines athletes and causes persistent pain for many people. To understand it properly, we've pulled insights from peer-reviewed orthopedic literature, including articles from the Journal of the American Academy of Orthopedic Surgeons, JAAOS, and reliable foundational resources like OrthoBullets. It's a complex corner of orthopedics, isn't it? Filled with nuanced anatomy and evolving treatment approaches, and we're going to guide you through the most important bits. I've always been fascinated by SLAP tears because they seem to be talked about constantly in sports medicine, but figuring out what's really going on and how to best fix them, well, it seems to be a source of ongoing debate.
Oh, absolutely. They are a real challenge in clinical practice. The symptoms can overlap with other shoulder issues. Imaging requires a discerning eye, and as the sources highlight, deciding on the optimal management strategy, especially for different patient profiles, involves navigating quite a few factors. There's no simple formula, really, which is why understanding the underlying anatomy and pathology is so critical.
Okay, let's unpack this then, starting with the absolute basics. We hear SLAP lesion. What exactly is this tear, and where is it located in the shoulder?
Right. So at its most fundamental, a SLAP lesion is an injury to the superior labrum of the shoulder. The acronym SLAP stands for superior labrum anterior and posterior.
Okay.
This means the tear is specifically located in the top, the superior portion of the ring of cartilage surrounding the shoulder socket. And the crucial characteristic defining this SLAP tear is that this tear involves the superior labrum, and critically, it extends from the front, the anterior, to the back, the posterior, encompassing the area where the long head of the biceps tendon attaches to the labrum.
Ah, I see. So it's not just any tear of that cartilage ring. It's a specific tear in the upper part, right where the biceps hooks in.
Precisely. Yeah, exactly. To fully appreciate this, let's maybe take a moment for a quick tour of the shoulder anatomy, as described in the sources. The shoulder is basically a ball and socket joint. You have the ball, which is the head of your humerus, your upper arm bone,
Right.
and it fits into a rather shallow socket on your shoulder blade, called the glenoid. Now, because that glenoid socket is relatively flat, the labrum comes into play.
And the labrum is what? Sort of like a bumper or a seal?
Yes, think of the labrum as a rim or a bumper. That's a good way to put it. It's a ring of tough fibrocartilaginous tissue that attaches around the edge of the glenoid socket. Its main job is really to deepen that socket, making the shoulder joint inherently more stable. It increases the contact area between the humerus and the glenoid.
Oh.
It helps keep the ball centered in the socket. Beyond deepening the socket, the labrum also serves as an important attachment point for some of the key ligaments that provide stability to the shoulder joint. And, as we just mentioned, it's the attachment site for the long head of the biceps tendon.
Right, let's zero in on that biceps connection then. It seems absolutely central to SLAP tears. How does the long head of the biceps attach there?
Okay, the long head of the biceps tendon actually originates just above the shoulder socket at a point called the supraglenoid tubercle on the scapula. It then travels through the shoulder joint before blending with and attaching to the superior portion of the labrum. According to anatomical descriptions in the sources, the long head of the biceps tendon commonly has a sort of split attachment. Roughly 50% of its fibers attach directly to the superior labrum,
50%.
and the other 50% attached to that bony supraglenoid tubercle. The tubercle itself is located about 6 millimeters medial or towards the body's midline from the actual articular surface of the glenoid. This point of attachment is generally located posterior to the 12 o'clock position on the superior glenoid when you're looking at it arthroscopically.
And you mentioned anatomical variations in how the biceps attaches. Does that add another layer of complexity?
It absolutely does, yes. The way the biceps tendon attaches to the superior labrum isn't identical in everyone. There's this thing called the Tuohedi classification system, referenced in the sources,
Right.
describes some of these patterns. Type I is where the attachment is completely posterior to that 12 o'clock position on the glenoid. Type 2 is predominantly posterior. Type 3 has fibrils attaching both anteriorly and posteriorly. And type 4 is when the entire attachment is anterior to the 12 o'clock position. Yeah. The sources indicate that top I and II attachments are by far the most common, accounting for over 70% of the anatomical variations observed.
Wow.
Okay. Understanding these normal variations is important because, well, they can influence how a tear presents or how a surgeon views the anatomy during surgery. Another relevant anatomical detail is that the long head of the biceps tendon, it actually has its porous blood supply, right, precisely where it traverses through the shoulder joint.
Ah, okay.
This limited blood flow could potentially impact its ability to heal after injury.
Limited blood flow. That sounds like a key piece of information. And what about the labrum itself? Does its blood supply vary?
Yes, it does. The labrum receives its blood supply not from the underlying bone, but from the surrounding joint capsule and periosteal vessels. And critically, the anterior superior portion of the labrum seems to have the poorest blood supply compared to other parts of the rim. Couple this with the fact that the superior labrum attaches slightly further medially on the glenoid compared to the inferior labrum, making it a bit less firmly supported at its base, you could say. And it becomes clearer why this specific area, where the biceps tendon anchors, can be considered something of a weak link. It's prone to injury under certain forces, resulting in a SLAP tear.
So the very anatomy of that superior labrum and biceps anchor area kind of predisposes it to tearing. And speaking of anatomy looking like tears, you mentioned those tricky anatomical variants that can sometimes fool even experienced eyes. That sounds like a major diagnostic hurdle.
It's a very significant point, yes, particularly for surgeons looking inside the joint. There are two main anatomical variants in the superior labrum area that can easily be mistaken for a tear on imaging or during arthroscopy if you're not acutely aware of them. One is called the sublabral recess or sublabral foramen. This is a normal, non-pathological separation or space between the superior labrum and the underlying glenoid bone. It's just how the anatomy is configured in some people. It can sometimes be associated with a thicker than usual middle glenohumeral ligament, which is another ligament in the shoulder.
Right.
The key challenge is distinguishing this normal space from a true tear, where the labrum is detached and actually causing symptoms. On an MRI arthrogram, dye might enter this normal recess, which can be confusing.
I can see that.
But the pattern is usually distinct from dye entering a tear. It tends to be smoother.
Okay, and the second variant?
The second crucial variant is the Buford complex. This is a specific anatomical arrangement where the middle glenohumeral ligament is very thick and cord-like, and it originates directly from the superior labrum. When this happens, there is a congenital absence, or a bare area, of the anterosuperior labrum. It looks like a piece of the labrum is missing or torn anteriorly.
But it's not.
But it's actually a normal developmental variant present in a small percentage of the population.
And why is recognizing the Buford complex so critical? What happens if a surgeon mistakes it for a tear and tries to fix that bare area?
This is where the clinical pitfall lies. It's really important. If a surgeon doesn't recognize the Buford complex and mistakenly repair that bare anterosuperior area of the labrum to the glenoid, believing it's a tear, they will significantly restrict the patient's external rotation of the shoulder.
Oh, wow.
Because that thick, cord-like ligament is meant to be in that position, trying to anchor tissue there that isn't supposed to be just restricts normal shoulder movement. Recognizing these variants, the sublabral recess and especially the Buford complex, is absolutely paramount for accurate diagnosis and avoiding unnecessary surgery that can actually cause functional problems.
That really emphasizes how understanding the normal variations is just as important as understanding the pathology. It's not just a simple case of, is there a tear or isn't there?
Okay, so we know what a SLAP lesion is anatomically and some of the quirks in that region. Who was most likely to get one of these tears and what typically causes them? Well, while SLAP lesions account for a relatively small percentage of all shoulder injuries, less than 5% according to the sources.
Less than 5%.
They are disproportionately seen in specific groups. The classic patient is the overhead or throwing athlete, often in their dominant arm, think baseball pitchers, javelin throwers, volleyball or tennis players, that sort of thing. However, they can also occur in older patients, particularly as a result of a traumatic fall onto an outstretched arm.
Are there specific risk factors or certain movements that are known to cause these tears?
Yes, repetitive overhead activities are the prime suspect in athletes. The sheer volume and force of throwing or suving motions put immense stress on that superior labrum and biceps anchor. Other common mechanisms of injury include falling directly onto an outstretched arm, especially if the arm is slightly bent and the biceps muscle is tensed at the time of impact. A sudden, forceful pull on the arm, like trying to catch a heavy object unexpectedly, or rapid, forceful movements of the arm above shoulder level can also generate enough force to tear the superior labrum. And interestingly, a shoulder dislocation can sometimes peel the labrum off the glenoid rim, occasionally including the superior portion involved in a SLAP tear.
You mentioned a theory about throwers specifically, linking tightness to the injury. Can you elaborate a bit on that biomechanics?
Absolutely. This is where some of the deeper insight into the pathology comes from. There's a well-regarded theory that in throwing athletes, who often develop tightness in the posterior capsule and the posterior inferior glenohumeral ligament.
Right, the back of the shoulder.
Exactly, which is a key stabilizing structure at the back and bottom of the shoulder. This tightness can alter the mechanics of the throwing motion. As the arm moves through the late cocking phase and into acceleration, this posterior tightness can cause the ball of the humerus to shift posterosuperiorly upwards and backwards relative to the glenoid socket.
Ah, okay.
This abnormal shift increases the shear force applied to the superior labrum, effectively sort of grinding or peeling it away from the bone, especially where the biceps tendon attaches. Furthermore, the sources point out that once a SLAP lesion is present, this detached superior labrum and biceps anchor can then increase the strain on the anterior band of the inferior glenohumeral ligament.
Which is the main stabilizer at the front.
Precisely, the primary anterior stabilizer of the shoulder. This can lead to a sort of vicious cycle where the SLAP tear contributes to subtle instability, further disrupting normal mechanics.
That's fascinating. So the injury itself can potentially worsen the underlying problem or contribute to instability. It's not just about the tear itself, but how the tear changes the shoulder's function. And you noted that in older patients, it might not be from trauma, but just wear and tear.
Correct, yeah. In individuals over the age of, say, 30 or 40, it's not uncommon to see some degree of fraying or degenerative changes in the superior labrum on MRI or during arthroscopy. This can just be a normal part of aging and doesn't necessarily cause symptoms or require treatment unless there was a specific traumatic event superimposed on these degenerative changes.
Right.
Differentiating between a symptomatic tear and just age-related fraying is another critical diagnostic step. It's not always easy.
And are SLAP tears usually isolated injuries, or do they often come with other problems in the shoulder joint?
They frequently have company, yes. SLAP lesions are often associated with other shoulder conditions, particularly in throwing athletes. These can include things like internal impingement.
Or the cuff gets pinched.
Yeah, where the rotator cuff tendon gets pinched in certain overhead positions. Also, glenohumeral internal rotation deficit, or GIRD, which is that posterior tightness we discussed. Rotator cuff tears are common too, often partial thickness tears on the articular or joint side. Subtle shoulder instability and scapular dyskinesis, that's abnormal movement or positioning of the shoulder blade during arm motion. Okay. Addressing these associated conditions is often really important for successful management, whether you go surgical or non-operative.
Okay, we understand the anatomy, who gets them, and how they might happen. Now, for the detective work, how do doctors actually figure out if someone has a SLAP tear? What does the patient feel, and what does the examination involve?
Right, well, from the patient's perspective, the symptoms of a SLAP tear can be somewhat inconsistent and often mimic other shoulder problems, which, as we said, is part of the diagnostic challenge. Common complaints include a deep, aching pain within the shoulder that's often difficult to localize precisely. People struggle to point exactly where it hurts. A key symptom is often mechanical. People describe hearing or feeling popping, clicking, catching, or grinding sensations in the shoulder with certain movements. Pain is typically aggravated by specific positions, especially those involving overhead activities or when lifting heavy objects. Athletes, particularly throwers, might notice a significant decrease in their performance, maybe loss of velocity or control, feeling weakness, or experiencing what's sometimes called a dead arm sensation after throwing.
The dead arm, yeah.
Some patients also report a feeling of apprehension, or like the shoulder might pop out, and studies suggest apprehension tests are actually positive in a high percentage, around 85% of patients with SLAP tears.
85%, that's quite high.
It is. Reduced range of motion or easy fatigability can also occur. And it's worth noting that sometimes symptoms might not fully manifest immediately after the injury, but rather develop gradually over time.
So the symptoms are broad and can sound like other things. How does a doctor approach trying to pin down if it's actually a SLAP tear?
Well, the diagnostic process begins, as with any injury really, with a detailed medical history. The doctor will ask about the onset of the pain, whether there's a specific injury or if it came on gradually, what activities make it worse, especially work or sports, the exact location and character of the pain. and any previous treatments they might have tried. The patient's age and activity level are also critical pieces of information.
Okay.
Following the history, a thorough physical examination is performed. This involves assessing the shoulder's range of motion in different planes, evaluating muscle strength, and testing the overall stability of the joint. A key component of the physical exam for suspected SLA key tears involves performing what are called provocative tests.
Provocative tests.
These are specific maneuvers where the doctor moves the patient's arm into positions designed to put stress on the superior labrum and biceps anchor to see if they can reproduce the patient's pain or mechanical symptoms.
Are these provocative tests definitive? Like, if one test is positive, you know for sure it's a SLAP tear.
This is a critical point from the sources and really highlights the diagnostic difficulty. There is no single physical examination test that is perfectly sensitive or specific for diagnosing a SLAP lesion on its own.
Right. No silver bullet test.
Exactly. A diagnosis is based on the combination of the patient's history, their reported symptoms, and the findings from multiple provocative tests, along with, of course, the imaging results. It's putting all the pieces together.
Can you walk us through a couple of these provocative tests and maybe explain why they might reproduce symptoms if a SLAP is present? What's the thinking behind them?
Certainly. The sources list several. Some are general biceps provocation tests like Speed's test or Jurgensen's test, though these can be positive with other biceps issues too, so they're not super specific. More specific SLAP tests include the active compression test, often known as O'Brien's test,
O'Brien's test. Yeah, I've heard of that one.
the Crank test, the dynamic labral shear test, and the Kibler anterior slide test. There are quite a few.
Well,
Let's look at the O'Brien's test as it's commonly used. The patient flexes their arm forward to 90 degrees, adducts it about 10-15 degrees across the body, and internally rotates it so the thumb points down.
right. Thumb down, arm across.
Exactly. The doctor then applies downward resistance, and the patient resists. This position, with the arm slightly across the body and internally rotated, is thought to put a twisting or torsional stress on the superior labrum and biceps anchor. Then the arm is externally rotated, so the palm is up and the resistance is applied again.
Okay.
A positive test is if the pain or clicking experience with the thumb down position is reduced or eliminated when the palm is up, particularly if the pain is felt deep inside the shoulder. The idea is that with the thumb down, the superior labrum is being loaded and perhaps peeled away slightly, while with the palm up, that stress is relieved.
I see. And the crank test, how does that one work?
For the crank test, the arm is abducted, so lifted away from the body to about 120 degrees. The doctor applies an axial load, basically pushing the humerus head into the socket gently, and then rotates the arm internally and externally. This maneuver is designed to try and catch or pinch a torn labral flap between the humerus head and the glenoid. It's trying to reproduce those catching or clicking mechanical symptoms. The presence of pain or a click, especially during external rotation with that axial load, can suggest a superior labral tear.
Right.
But again, it's crucial to remember, a positive result on any single test isn't proof positive. It just raises suspicion that needs to be confirmed by other means, like imaging.
That makes sense. You're essentially trying to manually stress that specific area where the tear might be to see if you can reproduce the patient's symptoms. Given that physical tests aren't definitive, imaging must play a really crucial role then. What do they use, and how good is it at actually seeing these tears?
You're right, imaging is essential. Standard x-rays are usually the first step, but they primarily show bone, not soft tissues like the labrum.
So they'll likely be normal.
Exactly. X-rays in a patient with a SLAP tear are typically normal. They're mostly useful for ruling out other potential causes of pain, like arthritis, bone spurs, or maybe a fracture.
Okay.
To visualize the labrum itself, magnetic resonance imaging, or MRI, is the primary tool. On a standard MRI, a SLAP tear might appear as increased signal, a brighter area on certain sequences. Particularly T2-weighted images between the superior labrum and the glenoid bone, usually posterior to where the biceps attaches. However, standard MRI sensitivity for detecting SLAP tears is only around 50%.
50%. That sounds pretty low, especially for such a key diagnostic tool.
It is quite low. It means it misses about half of them, although its specificity is higher, around 90%. So if it sees something, it's likely real, but it misses a lot.
So how do they improve its accuracy? There must be a better way.
This is where an MRI arthrogram becomes invaluable. This involves injecting a contrast agent, basically a dye, directly into the shoulder joint before the MRI scan is performed.
Injecting dye into the joint first.
Exactly. The dye fills the joint space. If there's a tear in the labrum, the dye will leak into that tear, highlighting the defect and making it much more visible on the scan. The sources are clear that an MRI arthrogram significantly increases the accuracy for diagnosing labral tears compared to a standard MRI. It's really the gold standard for imaging these.
Right.
You can visually distinguish between, say, a normal sublabral recess where the dye might pool slightly in a smooth pattern, and a true tear, where the dye seeps irregularly into the torn tissue or the defect.
Okay.
The presence of a paralabral ganglion cyst is another important imaging finding. These are fluid-filled sacs that often form adjacent to a labral tear, particularly in the sphenoglenoid notch near the shoulder blade.
A cyst near the tear.
Yes, and their presence on MRI is considered highly specific for an underlying labral tear, even if the tear itself is subtle or difficult to see directly on the scan. It's a strong secondary sign.
So, the diagnosis is really a puzzle pieced together from the patient's story, the physical exam findings, even if they're not definitive individually, and then ideally, a specific type of imaging, like an MRI arthrogram. Once a tear is identified, the sources talk about classification systems. Why bother classifying these tiers? What's the point?
Classification systems are used mainly to standardize the description of the tear pattern. This helps in communication among clinicians, surgeons, physios,
Okay.
and importantly, it helps guide treatment decisions. Different types of tears might be managed differently. The most widely referenced system is the Snyder classification, which initially described 4 main types based on the anatomical location and the involvement of the biceps tendon anchor.
Could you briefly explain those Snyder types for us? Type I to IV?
Certainly, let's run through them. Type I. This is considered more of a degenerative tear. It involves fraying of the superior labrum and sometimes the biceps tendon itself, but the key thing is the biceps anchor remains firmly attached to the glenoid. These account for about 11% of SLAP lesions.
Just fraying anchors okay. Got it.
Type 2. This is the most common type, particularly in throwing athletes, making up around 41% of cases. It involves fraying of the superior labrum and a detachment of the biceps tendon anchor from the superior glenoid. The labrum and biceps anchor are essentially peeled away from the bone.
Okay, that's the detached anchor one.
Exactly. Type 3. This is described as a bucket handle tear of the superior labrum. A flap of the labrum tears and can displace into the joint, but critically the biceps tendon anchor remains intact and attached to the glenoid. The biceps actually separates from the torn labral flap. These are about 33% of cases.
So the labrum tears, but the biceps anchor stays put.
Correct. And type 4. This is also a bucket handle tear like type 3, but in this case, the tear extends into the biceps tendon itself, and the biceps tendon anchor is also detached and remains attached to the torn labral flap. These are less common, around 15%.
Right, so the tear goes into the biceps tendon too, and the anchor comes off with it.
Precisely.
And there are more types added later. I think you mentioned Maffet.
Yes, that's right. The Maffet classification and others expanded the system to include tears extending into other parts of the labrum or associated with other ligamentous injuries. For example, type V is a type 2 tear that extends down and forward into the anteroinferior labrum, similar to a Bankart lesion which you see in dislocations.
Ah, okay.
Type 6 is a type 2 with an unstable labral flap, and type 7 involves extension into the middle glenohumeral ligament. There are even more types described, up to X, but
Yeah.
while these extended classifications exist, the Snyder R5 are really the foundational ones clinicians often refer back to.
Given the complexity in those variants we talked about, is classifying these tiers always straightforward, even when the surgeon is looking right at it during surgery?
Unfortunately, no. This is another challenge highlighted in the sources. There is significant inter-observer variability.
Meaning different surgeons might grade it differently.
Exactly. And even intra-observer variability, where the same surgeon might classify the same care differently if they looked at it again at different times. This variability really underscores the subjective nature of assessing these tiers, even with direct visualization during arthroscopy. It reinforces that it's not just a simple, clear-cut diagnosis or classification. There's judgment involved.
Okay, so we've diagnosed it, we've classified it maybe with some variability. How do you treat a SLAP tear? Is surgery always the answer, or is there a non-operative approach first?
The good news is that surgery is not always necessary, and the sources strongly recommend starting with non-operative treatment in most cases. This is considered the first line of management.
Okay, so try physio first. What does non-operative treatment typically involve?
Non-operative management includes several components. Firstly, rest or a modification of activities, especially avoiding the movements that cause pain that's particularly important for athletes, obviously. Secondly, a structured physical therapy program, or physio, is crucial. This therapy focuses on regaining full, pain-free range of motion, strengthening the muscles around the shoulder, especially the rotator cuff and the muscles that control the shoulder blade.
Addressing that scapular dyskinesis you mentioned.
Precisely, addressing scapular dyskinesis and, importantly, stretching out any associated tightness like GIRD, that posterior tightness. Thirdly, non-steroidal anti-inflammatory medications, NSAIDs, can be used to help manage pain and reduce inflammation. This non-operative approach is typically pursued for a significant period, usually between 3 and 6 months, to really see if symptoms improve.
3 to 6 months. Okay.
Corticosteroid injections into the shoulder joint can also be used, often to help calm inflammation, and sometimes as a diagnostic aid if the exact source of the pain is a bit unclear.
How effective is this non-operative approach, especially for that high-demand overhead athlete, the pitcher maybe, who wants to get back to throwing at full speed?
This is a key distinction made in the sources, and it's quite important.
Wow.
While non-operative treatment can be successful for some individuals, particularly those with lower activity demands or maybe more degenerative tiers, the data on high-level pitching athletes is less encouraging. The number of pitchers who successfully return to their prior level of performance using only non-surgical methods has been described in the literature as unsatisfactory.
Unsatisfactory. That's quite blunt.
It is. It's a critical insight. It suggests that for this specific, highly demanding population, non-operative treatment, while a necessary first step, often doesn't actually get them back to where they need to be competitively.
That makes sense, unfortunately for them. So if non-operative treatment fails, or perhaps if the tear is severe or unstable from the outset, surgery comes into consideration. What does that involve?
Surgical treatment for SLAP lesions is typically performed arthroscopically keyhole surgery using small incisions, a camera, the arthroscope, and specialized miniature instruments. The goal of surgery is to address the tear based on its type, the patient's age, their activity level, and the surgeon's assessment of stability and tissue quality. This is also the area where, particularly for type 2 tears, there is significant ongoing discussion and, as the sources call it, quite a bit of controversy.
Right. You mentioned controversy around type 2 tears. What's the debate here? What are the options?
Okay, the core debate for type 2 tears, remember they're the most common in throwers and involve the detached biceps anchor, is whether to actually repair the torn labrum and reattach the biceps anchor back to the bone.
The traditional approach.
The traditional approach, yes. Or, alternatively, whether to perform a procedure on the biceps tendon itself, either a tenotomy or a tenodesis, and essentially leave the superior labrum alone, or perhaps just debride it, trim it up.
Okay, let's clarify those biceps procedures again. What exactly are tenotomy and tenodesis?
Right. Biceps tenotomy is simply cutting the long head of the biceps tendon near its attachment inside the shoulder joint, allowing it to retract down the arm. It essentially removes the tension and pull on the superior labrum.
Just cut it loose.
Pretty much. Biceps tenodesis also involves cutting the tendon, but then the cut end is reattached, usually with an anchor or screw, to the humerus, the upper arm bone, lower down, typically outside the shoulder joint itself.
Okay, cut and reattach it lower down.
Exactly. Tenodesis is generally preferred over tenotomy in active patients because it helps maintain biceps strength and the normal shape of the muscle, preventing the potential cosmetic deformity called a Popeye muscle bulge that can sometimes occur with just a tenotomy.
Right, the Popeye bulge. So traditionally, type 2 tears, especially in younger athletes, were repaired. Why the shift towards considering tenodesis more often now?
This is really where the outcomes data is influencing practice. While repairing the labrum and biceps anchor seems intuitively correct, restoring the anatomy.
Yeah, it sounds like the right thing to do.
It does. But recent investigations have shown a notable disconnect. A high incidence of SLAP repairs being performed, but often disappointing return-to-play rates, particularly for pitchers. Studies cited in the sources have shown that return-to-play rates after SLAP repairs are significantly lower for pitchers compared to athletes in other overhead sports, like tennis or volleyball.
Lower for pitchers specifically.
Interesting. Yes. And importantly, return-to-play rates for throwers are actually similar whether they undergo a SLAP repair or a biceps tenodesis. So the repair doesn't seem to offer an advantage for getting back to pitching specifically.
So similar outcomes for return to play, but maybe other factors.
Exactly. Furthermore, the sources highlight a strong association between age and the success of SLAP repair. Failures after SLAP repair are specifically linked to patients over the age of 36.
Over 36, okay.
This suggests that perhaps tissue quality or healing potential might be poorer in older patients, making the repair less likely to hold reliably, or possibly leading to complications like stiffness, which we'll talk about. Because of these findings, poorer return to throwing after repair compared to non-throwing sports, similar return to throwing between repair and tenodesis, and higher failure and stiffness rates in older patients after repair, the general consensus among orthopedic surgeons. As reflected in the literature, is increasingly favoring biceps tenotomy or tenodesis, especially in patients over the age of 40.
Right, so over 40 lean towards the biceps procedure.
Generally, yes. For younger, high-level overhead athletes, the decision is still debated, it's more nuanced, but the pendulum is certainly swinging towards considering biceps procedures more frequently. Even in this group, if return to high-level throwing is the primary goal, simply due to the less than ideal results seen with repair in that specific population.
That's a really significant shift in thinking, isn't it? Moving away from trying to restore the anatomy with a repair towards essentially just offloading the biceps tension because the repair outcomes, particularly for throwers or older patients, haven't been as successful as everyone hoped. What about the other types of tears, types 1, 3, and 4?
Right, for type I tears, which are just fraying with an intact anchor, and maybe some type 3 or Phi tears involving less than one-third of the biceps tendon without significant symptoms after non-operative treatment, simple arthroscopic debridement is often sufficient.
Just trimming the frayed bits.
Exactly, just trimming away the unstable, frayed edges of the labrum or biceps. For type 4 tears, where more than one-third of the biceps tendon is involved, causing severe symptoms that haven't responded to non-operative care, the options are typically debridement, plus either labral repair or biceps tenodymitis. The choice here would again depend heavily on the patient's age, activity level, and the surgeon's preference, considering all the same factors we just discussed for type 2.
So treatment is highly individualized based on tear type, age, activity goals, and this evolving evidence. Once surgery is done, whichever route is chosen, what does the road to recovery look like? Rehabilitation must be absolutely critical.
Oh, rehabilitation is absolutely paramount to the success of any surgical intervention for a sessile tear, whether it's a repair or a biceps procedure. It's not optional, it's essential. It's a structured, multi-stage process that progresses gradually to protect the healing tissues while carefully restoring motion and strength.
Okay, what's the initial phase like after the surgery?
Immediately after surgery, the shoulder is typically immobilized in a sling. The duration varies depending on the surgery's complexity and the surgeon's protocol, but usually ranges from about 2 to 6 weeks. The initial phase, typically the first 1 to 4 weeks, focuses heavily on protection and controlled motion. Patients are usually allowed gentle passive range of motion, where the therapist moves the arm,
Okay.
and maybe some active assisted range of motion exercises, often in the scapular plane, which is arm moving slightly forward from the side, kind of a safe zone. Crucially, during this phase, it is vital to avoid any extremes of abduction and external rotation.
Right, don't stretch it out too much.
Exactly. And absolutely no resisted biceps exercises, especially if the biceps anchor was repaired, to protect that healing site. You want to pull on it.
Makes sense. What happens as you move beyond that initial protective phase, say after the first month or so?
Around weeks 4-6, as healing progresses and pain allows, the patient typically transitions to active range of motion exercises, trying to move the arm themselves under their own power. They also usually start isometric strengthening tensing muscles without actually moving the joint. The mid-stage, generally from week 6-12, involves progressing to more functional exercises and beginning light resistance strengthening, really focusing on the rotator cuff and those parascapular muscles, the ones controlling the shoulder blade. The goal is to build foundational strength and control.
Okay, building back the support system.
Precisely. The late stage, from 12 weeks onwards, involves advancing strengthening exercises, restoring full range of motion, and initiating sport-specific training if the patient is an athlete. This might involve progressive drills mimicking the movements required for their sport, like starting a throwing program.
When can someone realistically expect to return to full activity or sport after all this?
A typical return to full activity or sport after SLAP surgery is often quoted around 6 months. However, this timeline is highly variable. It really depends on the specific type and severity of the injury, the patient's individual healing rate, their overall health, and critically, their activity goals.
6 months is just a ballpark figure then.
Very much so. For throwing athletes, an early interval throwing program might begin around 3-4 months. But a full return to competitive pitching can easily take 6 months or even longer, sometimes 9 months to a year, to feel truly back to normal. The sources emphasize that complete recovery can take several months, particularly in more complicated cases. And diligently following the surgeon's post-operative instructions and the prescribed rehabilitation plan is absolutely vital for optimizing the outcome. You simply can't rush the biology of healing.
That sounds like a long and very dedicated process. What are the potential roadblocks or complications that can occur after SLAP surgery? What can go wrong?
Well, like any surgical procedure, there are potential complications. For SLAP repair specifically, the most common complication reported in the sources is post-operative stiffness. It occurs in a significant percentage of patients. One source mentioned around 78%.
78%. That's a very high number for stiffness. Are there specific factors that make someone more likely to experience stiffness after a SLAP repair?
Yes, the sources identify significant risk factors for post-operative stiffness after SLAP repair. A particularly strong risk factor seems to be performing an incidental SLAP repair in older patients, specifically those over the age of 45, when doing surgery for a different primary problem, such as a rotator cuff repair.
So finding a SLAP tear while fixing something else and deciding to repair it in an older patient is risky for stiffness.
Exactly. It reinforces the clinical trend away from routinely repairing these lesions in older patients and perhaps opting for a biceps procedure instead, which tends to have less risk of stiffness.
And if someone does develop stiffness, how is it treated? Can it be fixed?
Early recognition and intervention are key. Rehabilitation protocols are designed to start controlled motion relatively early, even in the protective phase. Things like pendulum swings are often encouraged, sometimes beginning as early as 1 week post-op, specifically to help prevent stiffness setting in. If stiffness develops and persists despite dedicated physio, a secondary procedure called a capsular release might be necessary. This involves arthroscopically releasing the tightened tissues, the capsule, around the joint to restore motion.
Okay. Are there other potential complications besides stiffness?
Yes, other potential complications include, though less commonly, injury to the suprascapular nerve. This is a nerve near the shoulder blade that controls some of the rotator cuff muscles. This could potentially happen if the glenoid bone is over-drilled during the process of placing anchors for a repair, as the nerve runs quite close by. Careful technique is needed.
Right.
And unfortunately, sometimes the SLAP repair simply fails, or the patient continues to experience symptoms despite the surgery.
What typically causes a failed SLAP repair? Why might it not work?
Failures can be multifactorial. There isn't always one single reason. Causes can include the repair anchors pulling out of the bone, failure of the labral tissue itself to heal back to the bone properly, or perhaps the presence of associated injuries like articular cartilage damage that weren't fully addressed initially or that progressed over time. The sources again highlight the association of failures with age, specifically noting that failures are more common in patients over the age of 36.
Right, reinforcing that age factor again.
Exactly. Further supporting the rationale for considering biceps tenodesis in this age group. It's also really important to note that the outcomes after surgical management of a failed SLAP repair, so going back in to try and revise the initial surgery, are generally inferior to the outcomes achieved after a successful primary repair.
So it's much better to get it right the first time.
Absolutely. It really emphasizes the importance of selecting the right procedure for the right patient the first time around.
So getting that initial treatment decision correct, based on all the factors, age, activity, tear type, evidence, is really paramount for the best chance of success. Putting it all together then, what's the overall prognosis for someone who undergoes treatment for a SLAP tear? What can they expect?
Well, the prognosis for a SLAP after treatment is generally positive in terms of reducing pain and improving shoulder strength for the majority of patients, particularly those with symptoms directly attributable to the tear who undergo appropriate surgical intervention after feeling a good course of non-operative care. However, as we've discussed quite a bit, the ability to return to a prior high level of performance, especially for elite overhead throwers, remains variable and can be unpredictable. It's not guaranteed. Achieving a successful outcome relies heavily on the correct diagnosis in the first place, appropriate treatment selection tailored to the individual, addressing any associated shoulder pathologies concurrently, and critically, the patient's commitment to that structured and often lengthy post-operative rehabilitation process. It really is a complex injury requiring a comprehensive approach from everyone involved.
This has truly been a deep dive into the world of SLAP lesions. We've covered the nuanced anatomy, including those tricky variants like the Buford complex, gone through the detective work of diagnosis using history, physical exam, and specialized imaging like MRI arthrograms, and explored the evolving and sometimes controversial landscape of treatment decisions, particularly that shift towards biceps procedures for type 2 pairs in certain patient populations. Plus, the challenges of rehabilitation and potential complications like that significant risk of stiffness. It's absolutely clear that this is far from a simple injury, and managing it effectively requires a deep understanding of all these interconnected factors.
That's a very accurate summary, I think. The diagnostic challenges, the importance of recognizing anatomical variants, the controversies surrounding the optimal management of type 2 carry, especially in different age groups and activity levels, and the critical role of rehabilitation. Those are all key takeaways from the literature we reviewed today.
And understanding why certain decisions are made, like opting for a biceps tenodesis over a repair in an older patient because of that increased risk of failure or stiffness, that's crucial information for both clinicians and patients to understand, isn't it?
Indeed. And the evidence base is constantly evolving, which is why this area remains a topic of significant research and clinical discussion. It keeps changing.
Okay, thinking about everything we've covered, the anatomical complexities, the difficulty in definitively diagnosing these tiers sometimes, the ongoing debate about the best way to fix certain types, especially for athletes trying to get back to peak performance, and the impact of age on outcomes and complications. Here's a provocative thought to leave you, our listeners, with. Given these persistent challenges, how might future advancements, maybe in areas like artificial intelligence, helping to analyze subtle patterns on MRI scans, or more sophisticated biomechanical modeling to understand forces on the labor in real time during movement, or even biological approaches to enhance labral healing itself, how might these things fundamentally change how we diagnose and treat SLAP tears in the future? Could we reach a point where we can much more accurately predict who needs what treatment and who is most likely to achieve their desired outcome? Or conversely, is the inherent variability in human anatomy, tissue quality, and individual healing potential simply something we will always have to navigate with clinical judgment and experience no matter how good the tech gets?
Those are certainly the questions driving future research and innovation in orthopedic sports medicine. Big questions for the future.
This has been The Deep Dive. We hope this detailed exploration has given you a clearer picture of SLAP lesions. If you found this insightful, please do consider rating and sharing this deep dive with colleagues or friends who might find it useful.
Thank you for joining us.